Hello everyone, I am myself Dr. Rajesh Gubba. In this particular session, I'll be continuing the ECG, that is the continuation of the QRS complex. So in the previous session, like we have discussed the QRS complex and its abnormalities. Now let me dissect that QRS complex, and in this session, I'll be discussing about the abnormalities of the Q wave and as well as the abnormalities of the R wave. So we know the basics of it, that is the Q wave, it is due to the septal depolarization, and this Q wave which is due to septal depolarization, it is a negative wave, right? That means it is present below the isoelectric baseline. Now the question is, direction of septal depolarization is right to left, left to right, towards the apex of the heart, towards the base of the heart. So if you see the direction of the septal depolarization, it is from left to right. That is the reason why you have the Q wave being negative, which is present below the isoelectric baseline. Now let me show you that complex as well. This is the Q wave, which is a negative wave below the isoelectric baseline. So this is the lead, and if you take the direction of depolarization of septal depolarization, that is from left to right. So it is because from left to right, which is away from the electrode, that is the reason why the Q wave is being negative. Now what will be the amplitude of this particular Q wave? The amplitude of the Q wave is different in the different leads, but overall if you observe the Q wave, it is like very small. Now you should also understand the concept of why the Q wave is very small in all the leads. Let me tell you. Now this particular electrode, it has to pick up the electrical activity of the septum, but between the septum and as well as the electrode, you have a thick myocardium. So the electrical activity has to be picked up from the septum through the ventricular myocardium by the electrode. So that is the reason why the Q wave, it will be very small. But in some of the leads, the Q waves, they are not at all seen or they are not at all observed. In which leads? Let me show you that. Okay. So if you take mainly the leads V1, V2 and as well as V3, more or less the Q waves are absent. I'll tell you the reason why. Because if you take the lead V1, V2, V3, where do we usually place them? They are mainly the right-sided leads. So this is V1 and this is V2 and this is V3. Then we have V4, then V5 and then V6. So this is what is the placement of the leads over the precordium. You take the direction of the septal depolarization towards V1, V2, V3. So the direction of septal depolarization, it is towards V1, V2, V3. That is the reason why in lead V1, V2, V3, usually you don't have the Q waves at all. If there is appearance of the Q wave in V1, V2, V3, they are considered to be the pathological Q waves. They are considered to be the pathological Q waves. Okay. And whereas you take the other leads, you take the later leads like 1 AVL, V5, V6, you will definitely have a small septal Q wave, because you take this V5, V6, this V5, V6, you know, it is picking up the electrical activity from the septum, which is having the direction of depolarization away from V5 to V6. So that is the reason why you have a small Q wave in V5, V6 and as well as 1 and AVL. Now, you should know what is the normal Q wave, what is the pathological Q wave. You see this question now. All of the following are the features of the pathological Q wave, except the options are more than 40 milliseconds, more than 2 mm deep, more than 25% depth of the QRS complex, less than 1 mm wide. So the question is, which among the following is not the feature of the pathological Q wave? So to consider it as pathological Q wave, it should be more than 40 milliseconds wide. More than 40 milliseconds wide means like one small box, and more than 2 mm deep, that means two small boxes, and it should be more than 25% of depth of the QRS complex. But remember, what is the point which is against going towards your pathological Q wave is less than 1 mm wide. So if it is less than 1 mm wide, it is considered to be the normal Q wave. It is not pathological Q wave. Okay. Now let me show you the ECG with pathological Q wave. So you see this. This is the ECG with pathological Q wave. Okay. So you can observe the depth of these particular Q waves in the inferior leads. They are more than 2 mm deep. Okay. And if you take the width, they are occupying more than one small box. So it is almost more than 40 milliseconds. That is also the criteria to call it as the pathological Q wave. And next important is, if you see the depth of this Q wave, right? If you see the depth of this Q wave, the depth of this Q wave, it is almost more than 25% of the QRS complex. So that is also considered as a pathological Q wave. Okay, right. Now anything less than this will be the normal Q wave. Now what are the differential diagnoses for the appearance of the Q wave? Now you see this question, very important. Deep dagger shaped Q waves are seen in myocardial infarction, hypertrophic cardiomyopathy, lead placement error, rotation of the heart. Now if you see what are all the various differential diagnoses for the appearance of the pathological Q wave, in case of myocardial infarction, there will be pathological Q wave. In hypertrophic cardiomyopathy, you will have pathological Q wave. And rotation of the heart, you will have pathological Q wave. Lead placement error, you will have the pathological Q wave. But the question is very clear that where is deep dagger shaped Q waves? Deep dagger shaped Q waves are classically seen in patients with a hypertrophic cardiomyopathy, right? Now, let me show you that. So in case of hypertrophic cardiomyopathy, you will notice that the septum, it is hypertrophy. You have two forms of hypertrophic cardiomyopathy. One is septal hypertrophy and the other one is apical hypertrophy. In case of septal hypertrophy, you have this deep dagger shaped Q waves. Okay. Now, yes, these are what is nothing but the deep dagger shaped Q waves, which are mainly present within the lateral leads. That is 1 AVL, V5 and V6 particularly. Okay. Now you have to understand what is the treatment for this hypertrophic obstructive cardiomyopathy. The drug of choice for these individuals will be the beta blockers. Now why? What is the mechanism you are having this deep dagger shaped Q waves? Why? Because if you see the septum, it is hypertrophied septum. So if you take this leads V5 and as well as V6, now the septal depolarization is from left to right. So the strength of depolarization which is going away from V5, V6 is more than normal because the septum is hypertrophied. So the strength of depolarization which is moving away from V5, V6 is more than normal. So that is the reason why the Q wave, it is considered to be a pathological Q wave, right? Q wave is considered to be the pathological Q wave. Okay, right. Next, the other condition where you will have the pathological Q wave is in patients with myocardial infarction. So you take in any form of MI, you take anterior wall MI, lateral wall MI or inferior wall MI, you will have the appearance of the Q wave. The reason why? What is the mechanism? The mechanism is that, see, now why is that the Q waves being very small? Because you are having the presence of this myocardium. Okay, so this myocardium, whichever is there, this will be acting as, you know, a closed window for this electrode, and the electrical activity which is being picked up, right? The electrical activity which is being picked up from the septum will be less because the myocardium will be acting as a window, closed window. Now, whenever there is myocardial infarction, remember this particular window, it gets opened, right? So, you know, this lead V6, this is now directly able to pick up the electrical activity from the septum. So when V6 is like directly picking up the electrical activity from the septum, septal depolarization is away from V5, V6. So thereby you will have a deep Q wave, which is nothing but a pathological Q wave, right? Which is nothing but the pathological Q wave. So the differential diagnosis for the appearance of the pathological Q wave is number 1, myocardial infarction. Number 2, hypertrophic obstructive cardiomyopathy. Number 3, extreme clockwise or counterclockwise rotation. Number 4, lead placement error, where the upper limb leads placed on the lower limbs and lower limb leads placed on the upper limbs. So these are the differential diagnosis for the pathological Q wave. Now you take this myocardial infarction. In case of myocardial infarction, let me tell you, you will get this Q wave in case of a fully evolved MI. What do you mean by the word fully evolved MI? The entire myocardium is completely dead. That is called fully evolved MI. And the other areas of MI where you can have this pathological Q wave is in patients with old MI. Right? In patients with old MI, there also you have this pathological Q wave. Now, you see this ECG and identify the diagnosis. So, identify the ECG, anterior wall MI, inferior wall MI, lateral wall MI and posterior wall MI. Now, the leads which have been mentioned here is the leads of V1, V2, V3, V4, V5 and as well as V6. These are the ventricular leads or precordial leads. So in this, what are the abnormalities you are observing? You are observing that there is ST segment elevation in V1, V2, V3 and as well as V4. Along with this ST segment elevation from V1 to V4, there is also the appearance of the pathological Q waves. Okay, so presence of pathological Q waves along with ST segment elevation in V1 to V4. V1 to V4, what are those? They are considered as the anterior leads. Right, they are considered as the anterior leads. So in V1 to V4, which are the anterior leads, you are having ST segment elevation, and this is considered to be a fully evolved anterior wall MI. Okay, next, then followed by that, you see the next, yes, so this is the ECG of fully evolved anterior wall MI. Now, you need to know next one, identify the abnormality in this particular ECG. So already I have given you the arrow marks where you have the abnormality, where you have, the pathological Q waves in 2,3 AVF. So 2,3 AVF, what are they? They are considered as the inferior leads, right? But do you have the ST segment elevation here? No, ST segment elevation is not there. But you have only Q wave. So, where in the inferior leads. So, this is suggestive of the previous myocardial infarction. So, I said you two scenarios of MI where you can have the pathological Q wave. One is fully evolved MI. Number 2, the old MI. Right? Number 2, the old MI. So, these are the two scenarios where you can have the pathological Q wave. So, this is about the differential diagnosis for the pathological Q wave. Now, after having discussed about the Q wave, let me discuss about the R wave. So R wave, it represents the depolarization of the ventricular wall. Okay, it represents the depolarization of the ventricular wall. And the ventricular wall depolarization, right? This ventricular wall depolarization, it is towards the electrodes, right? It is towards the electrode, V2, V3, V4, V5 and then V6. So that is the reason why the R wave, it is a positive wave. Now, what all will be the abnormalities of the R wave? I'll discuss. The abnormalities of the R wave that you need to know is, you take lead V1, in lead V1, you don't have the R wave. But the abnormalities what I'll be discussing is the conditions where you have dominant R wave in V1. That is one abnormality, right? Next. Second important abnormality is, if you move from V1 to V2 and V2 to V3 and then V3 to V4, from V4 to V5 and from V5 to V6. So if you move from V1 to V6, what is that you are observing? You are observing the progression of the R wave. Right? You are observing that there is progression of the R wave. But we have some conditions where there is poor progression of the R wave, right? We have some conditions where there is poor progression of the R wave. What are those abnormal conditions? We will discuss. Third important abnormality is you take AVR. In lead AVR, you don't have a positive complex. It's a completely negative complex. Why? Because lead AVR is that it's an augmenting the right arm. The entire electrical activity, it moves away from the right arm. So that is the reason why AVR is like having global negativity. P wave, QRS complex, T wave, everything will be negative. But then what is the abnormality? The third abnormality is, I'll tell you the conditions where you have dominant R wave in the AVR. So three important abnormalities now. Number one, the presence of dominant R wave in V1. Number two, what are the conditions where you have poor progression of the R wave? Number three, what are the conditions where you will have dominant R wave in AVR? So these three, let me discuss now one by one, right? So first of all, you need to understand what is the concept of the progression of the R wave. So when you move from, okay, so where will be the electrical activity starting? The electrical activity, right? The electrical activity, it will be starting from the SA node and gradually it will be progressing towards the left ventricle. That means the electrical activity, the direction of the electrical activity, when you compare that with your precordial leads, V1, V2, V3, V4, V5, V6, the electrical activity, it is moving away from V1, V2, and slowly it is moving, the electrical activity is moving towards your V4, V5, and as well as V6, right? The electrical activity is moving towards your V4, V5, and as well as V6. So that is the reason why you take this ECG now. V1, V2, V3, you have small R waves, but by the time you reach V4, V5, and V6, you can observe that there is prominent R wave. You can observe that there is presence of the prominent R wave. Okay, right. So that is what is the reason of or concept of the R wave progression, right? Now let me take up the abnormalities of the R wave. That includes, number one, dominant R wave in V1. What are those conditions? I will discuss. Dominant R wave in AVR. What are those conditions? I will discuss. What are the conditions where you will have poor R wave progression? Okay. Now, first let me discuss the presence of dominant R wave in V1. Okay, you see this. In all of the following conditions, dominant R wave is there in V1 or dominant R wave in V1 is seen, except the options are right ventricular hypertrophy, left bundle branch block, right bundle branch block, and then the posterior wall MI. So in which clinical scenario you will not have a dominant R wave in V1 is, that is in patients with left bundle branch block. In patients with left bundle branch block, you will not have a dominant R wave. You will have deep, wide S wave, right? Deep and broad S wave in lead V1. Whereas you take all other conditions, right ventricular hypertrophy, RBBB, and as well as posterior wall MI, you will have the presence of dominant R wave in V1 or else in V2 as well. Okay. Now, let me show you the ECG of LBBB. So in LBBB, you will have deep and broad S wave in V1 and you will have tall, broad R wave in V6. That is what you will observe in the left bundle branch block. And in left bundle branch block, what is the very, very important manifestation? The very important manifestation is the presence of, right, or the development of the wide QRS complex. That is the earliest manifestation. And what are the other manifestations we have discussed just now? You will have deep, broad S wave in V1, broad, tall R wave in V6. That is what you will see in left bundle branch block. Okay. Now, what are the causes of dominant R wave in V1? Let me tell you all the conditions. So you will have dominant R wave in V1 in right ventricular hypertrophy, then in patients with right bundle branch block, in patients with the posterior wall MI, then you have this dominant R wave in V1 in some congenital disorders also. What are those congenital disorders? Like in patients with Duchenne's muscular dystrophy, which is nothing but a congenital muscular dystrophy, right? Then you can also have a dominant R wave in V1 in cases of right, in cases of the dextrocardia. And you can also have that in patients with hypertrophic cardiomyopathy, and in children, the presence of dominant R wave in V1, it is considered to be the normal variant. It is considered to be the normal variant. Okay, right. Now I'll show you the ECGs of all these conditions with the dominant R wave. Okay, right. So you see this. The question is, okay, I'll show you all those conditions by giving you the MCQs, clinical patterns, and ECGs, right? 56-year male, chronic smoker, presented with pedal edema and ascites. ECG is as follows. What is the diagnosis? The options are pulmonary embolism with right ventricular hypertrophy, left ventricular hypertrophy, acute left ventricular failure, then the emphysema. Okay. Now, if you observe here, the patient is a chronic smoker. So definitely he will develop some lung pathology. Okay, right? And he presented with pedal edema and ascites. So the presence of pedal edema and ascites in a background scenario of lung pathology, you need to understand that he might have developed cor pulmonale, okay, where he has progressed to development of the right ventricular failure also. So it is because of right ventricular failure, there is development of pedal edema and as well as the ascites. Now, which among the options which has been given to you is responsible for the development of cor pulmonale in a smoker? That is the emphysema. So in patients with emphysema, it is more common in smokers. That is nothing but COPD. And in emphysema, what they will have is they will have development of hypoxia. Whenever there is hypoxia, pulmonary artery vasoconstriction will develop. Once there is pulmonary artery vasoconstriction, what will happen is there will be pulmonary hypertension. Once there is pulmonary hypertension, there will be increased afterload on the right ventricle, and that increased afterload on the right ventricle is what is responsible for right ventricular hypertrophy. Okay, so this is the ECG of right ventricular hypertrophy, where you have the presence of dominant R wave in V1. And in right ventricular hypertrophy, what are the other ECG changes? The other ECG changes in right ventricular hypertrophy is you have the presence of the right ventricular strain pattern. What do you mean by the word right ventricular strain pattern? Right ventricular strain pattern means in right ventricular hypertrophy, you will have the T wave inversion, and this particular T wave inversion, it is of asymmetrical T wave inversion. Right? It is of the asymmetrical T wave inversion, which is the strain pattern. You understand? Now, the next important point is these patients with right ventricular hypertrophy, they also have the development of deep S wave. Right? They also have the development of deep S wave in lead V6. That is what is another important criteria for the right ventricular hypertrophy. Now, what should be the dimension of the R wave in V1 to call it as right ventricular hypertrophy? The amplitude of the R wave in V1, it should be around 6 millimeters to call it as right ventricular hypertrophy. And what should happen to the R by S ratio? The R by S ratio in lead V1, it should be more than 1. Right? In lead V1, it should be more than 1. And if you take the depth of the S wave in V5 and as well as V6, in V5, the depth of the S wave, it should be more than 1 millivolt, which is nothing but more than 10 mm. In V6, the depth of the S wave should be more than 0.3 millivolt, which is nothing but more than 3 mm. Right? The depth of the S wave should be more than 3 mm in the V6. Okay. And in AVR also, you will have the dominant R wave in case of right ventricular hypertrophy. And how much will be the dominant R wave in AVR? That should be more than 4 mm. Right? That should be more than 4 mm. So this is what is the criteria for the right ventricular hypertrophy. Right? Now, apart from right ventricular hypertrophy, okay, let me explain you the reason also why you have a dominant R wave in V1 and why you have a deep S wave in V6. Let me explain you the concept. So the concept is that you take in patients with right ventricular hypertrophy, what will be the direction of the net electrical activity? In right ventricular hypertrophy, the direction of the net electrical activity is towards the right-sided leads. Why is that in a normal individual, the direction of depolarization is towards left ventricle? Because left ventricle is more thick than compared to right ventricle. So the net electrical activity will move towards your left ventricle. Thereby you have the progression of R wave from V1 to V6. But whenever there is right ventricular hypertrophy, when right ventricle is more thick than compared to that of the left ventricle, the net electrical activity will move towards your right sided leads, that is V1, V2, V3. That is the reason why in right sided leads you have the dominant R wave in V1, V2 and as well as V3. Now why is that you are having the deep S wave? Because the electrical activity is moving away from your V6, right? When the electrical activity is moving away from the V6, away from your left ventricle, the S wave, which is representing the negative component, that will be more deep. Okay, so this is the concept of dominant R wave in V1 and deep S wave in V6 in patients with the right ventricular hypertrophy, right? So now let me take up the discussion of the next important clinical scenario and other condition where you have a dominant R wave in V1. So the question is, a 42-year female presented with a history of dyspnea, and on examination there is a wide fixed split on auscultation. The ECG is as follows. Right, so this is the ECG and the options are right bundle branch block, left bundle branch block, right ventricular hypertrophy and ventricular septal defect. So if you observe the ECG very clearly here, in this also you have the presence of dominant R wave in V1. And if you closely observe the QRS complexes, the QRS complexes, they are wide QRS. If you observe the QRS complexes, they are the wide QRS complexes. Now, the point is, in which condition you will have wide QRS complex with the following pattern of the R wave. Actually, the description of the R wave in V1 here, this we call it as RSR dash pattern. So this is called as RSR dash pattern in lead V1. Now, what is the condition where you will have RSR dash pattern in lead V1? That you will have in patients with right bundle branch block. Okay, so another condition where you will have dominant R wave in V1 is RBBB, right bundle branch block, and this is how the ECG of right bundle branch block will be. Now, what is the reason for the fixed split on auscultation in this patient? See, one of the common condition where you will have wide fixed split in the second heart sound is you come across this in patients with the ASD. In patients with atrial septal defect, you will have wide fixed split in the second heart sound. And in patients with the atrial septal defect, there will be development of pulmonary hypertension, there will be development of right ventricular hypertrophy, and subsequently there can be development of the right bundle branch block as well. Okay, so patients with ASD, they can also develop RVH, but this is not the ECG of right ventricular hypertrophy because there is presence of wide QRS complexes. In case of right ventricular hypertrophy, you don't have the wide QRS complexes. So this is the ECG of the right bundle branch block. Okay, next, you see the next important clinical scenario. All of the following are the causes of the right bundle branch block except. So this question is basically about the etiology of RBBB. So right ventricular hypertrophy can cause the right bundle branch block. Pulmonary embolism, that will increase the afterload on the right ventricle, causing right ventricular hypertrophy, and thereby there will be development of right bundle branch block. Ischemic heart diseases, particularly right ventricular myocardial infarction, they will also cause the right bundle branch block. But remember, infective endocarditis will not cause the right bundle branch block. Now, what are the other conditions for RBBB apart from the first three options? You can also have the RBBB in patients with the rheumatic heart disease. You can also have the development of RBBB in patients with the myocarditis or the cardiomyopathy. You can also have the development of RBBB in degenerative diseases of the heart. And this degenerative diseases of the heart or degenerative diseases of the conducting system. And what is the example of the degenerative diseases of the conducting system? That includes Leves and as well as Lenegre's disease. And the congenital disorder which will cause the right bundle branch block will be atrial septal defect. So these are the conditions causing the RBBB where you will have a dominant R wave in lead V1, right? Next, you see the next important clinical scenario and as well as the ECG. So the question is, 56-year male presented with chest pain, coronary angiogram was done. Which vessel has the lesion in this particular patient likely to be? The options are left anterior descending artery, left main coronary artery, right coronary artery, and left circumflex artery. So if you see the ECG here, right, so you can observe you don't have that particular dominant R wave in V1, but you have a dominant R wave in V2 and as well as V3. Even in V2, V3 also you don't have a dominant R wave in a normal individual, but this patient is having chest pain. Along with that, you have a dominant R wave in V1, V2, V3. Okay. Along with the presence of dominant R wave in V1, V2, V3, there is also ST segment depression, right? And if you take the R by S ratio, either in V1, the R by S ratio is more or less equal to 1. But if you take R by S ratio in lead V2, it is definitely more than 1. So these points, they are very much suggestive of, okay, what are the other abnormality in this ECG? The other abnormalities that you can find is in lead 2, lead 3 and AVF, there is ST segment elevation. So in lead 2, 3 AVF, if there is ST segment elevation, that is suggestive of the inferior wall MI, right? The inferior wall MI is caused by the blockade of the right coronary artery. And one of the branch of the right coronary artery, it is posterior interventricular artery. So this posterior descending artery or posterior interventricular descending artery, once that is being blocked, the individual will develop posterior wall MI. So whatever these particular changes are there, that is dominant R wave in V2, V3, R by S ratio more than 1, all these are suggestive of the posterior wall MI. So for the development of the inferior wall MI and as well as the posterior wall MI, the vessel that is being blocked will be the right coronary artery. So what I wanted to show you is, I wanted to show you the condition where you will have a dominant R wave in MI, that is in posterior wall MI, you will have a dominant R wave in V1, V2 and as well as V3, right? Now, then whenever you are suspecting the posterior wall MI like this, right, you have put the precordial leads from V1 to V6. So you need to do the adjustment of these precordial leads in order to have the ST segment elevation in the posterior wall MI. What are that adjustments? I'll show you. So the leads which you have placed in V1, V2, V3, you have to readjust it to V4, V5, V6, right? V1, V2, V3, you place it in V4, V5, V6, and that V4, V5, V6, you need to readjust to V7, V8 and as well as V9. You have to readjust it to V7, V8 and as well as V9. Now, in the following manner, when the leads have been placed, if you take an ECG, like you will notice the ST segment elevation in V7, V8 and as well as V9, you have the ST segment elevation. So V7, V8, V9, you have the ST segment elevation in the posterior leads. Okay. So in posterior wall MI, you will have the ST segment elevation in V7, V8 and as well as V9, right? So that is about the presence of dominant R wave in posterior wall MI. Now, I'll show you one more ECG with dominant R wave in lead V1. Okay. You see the clinical scenario. The clinical scenario is, we have a 32-year male patient presented with history of chest pain since 1 day. He says after taking a pill, his chest pain has further increased. ECG of the patient is as follows. What is that particular pill the individual is taking? The options are aspirin, nitrate, clopidogrel and then metoprolol. So first of all, you need to understand what is the diagnosis of this particular ECG. So this patient having chest pain is increasing upon taking the pill, and if you take the description of the ECG, what all abnormalities are there in this, I'll show you. So number one, you have a dominant R wave in V1. That is one thing. Next, you have the presence of dagger-shaped Q waves in V5 and as well as V6. You have the presence of dagger-shaped Q waves in V5 and as well as V6. And then you are also having dagger-shaped Q waves in 2-3 AVF. So the presence of dagger-shaped Q waves, in which clinical condition you will have that? You will have that in patients with the hypertrophic obstructive cardiomyopathy. Right? In patients with hypertrophic obstructive cardiomyopathy, you will have the presence of deep dagger-shaped Q waves. And in patients with hypertrophic obstructive cardiomyopathy, you also have the asymmetrical T wave inversion. So you can see that here. So this is the T wave inversion. So this is the asymmetrical T wave inversion which is present in the V5 and as well as V6. Okay. Now the point is, in patients with HOCM, Upon supplementing which particular drug, there will be increase in the chest pain. So usually for angina, we give nitrates. That is for angina of ischemic heart diseases. But angina of hypertrophic cardiomyopathy, when you give nitrates, the angina or the chest pain further gets precipitated. Okay. So why? Because whenever you give nitrates in patients with hypertrophic obstructive cardiomyopathy, nitrates will reduce the venous return. Once the venous return reduces, the LV volume further reduces, and thereby there will be increase in the obstruction. Once there is increase in the obstruction, the cardiac output reduces, so the myocardial perfusion reduces, and thereby the angina increases. So in patients with hypertrophic obstructive cardiomyopathy, remember, whenever you give nitrates, the chest pain increases, and this is one condition where you will have a dominant R wave in V1. Okay. Now, one more clinical scenario where you will have the presence of the dominant R wave in AVR. Okay. You see here, you have the presence of dominant R wave in AVR to small extent. Right. And what are the abnormalities? We'll discuss after discussing the question. So, 18-year male presented with history of copious expectoration, ECG shown is as follows. What is the diagnosis? Young syndrome, Carter-Jenner syndrome, William Campbell syndrome, incorrect lead placement. Okay. So what all abnormalities you are finding in this particular ECG? Let me discuss. One is you are having a dominant R wave in AVR. That is one particular abnormality. Okay. Second abnormality, if you observe here, you take the R wave from V1, V2, V3, V4, V5 and V6. So is there progression of the R wave in the precordial leads? No. So there is poor progression of the R wave in the precordial leads, and you have a dominant R wave in AVR. And one more point, if you observe here very carefully, lead 1, it is having the global negativity. So P wave is negative, QRS complex is negative, and T wave is also negative. And so where do you come across these changes? Global negativity in lead 1, dominant R wave in AVR, poor progression of the R wave in precordial leads. You come across these changes in patients with dextrocardia. Now, you need to know which among the options which have been given to you are the one having dextrocardia. So, like you take the options in patients with Young syndrome, there is no dextrocardia. Carter-Jenner syndrome, it is nothing but immotile cilia syndrome. In these patients with Carter-Jenner syndrome, you have 4 important components. What are these 4 components of Carter-Jenner syndrome? So, the mnemonic for Carter-Jenner syndrome is RIBS. What does this RIBS stands for? R stands for rhinosinusitis, I stands for the infertility, B stands for bronchiectasis, S stands for the situs inversus. Right? Situs inversus. So, now as a part of this particular situs inversus, you have the presence of the dextrocardia, right? You have the presence of the dextrocardia. Whereas you take in all other options, you don't have the situs inversus or dextrocardia. But all these can contribute to the development of the bronchiectasis. Young syndrome, bronchiectasis can be there. Carter-Jenner syndrome, bronchiectasis can be there. Williams-Campbell syndrome, bronchiectasis can be there. So, because of this bronchiectasis only, you have the presence of copious expectoration in this patient. So, this is the ECG suggestive of dextrocardia. So what I want to tell you is, in dextrocardia you will have a dominant R wave in AVR and there is poor progression of the R wave. And next important is, usually there should be even the right axis deviation as well. Okay, so these are the ECG changes in patients with the dextrocardia. Now the next important clinical scenario you see here, 15-year male patients presenting with dyspnea. ECG is as follows. What is the diagnosis? The options are, what is the sign which will be present in this patient? 15-year male patient presenting with dyspnea. The options are, the patient may have Gower sign, the patient may have Babinski sign, patient may have Kussmaul sign, patient may have the square root sign. So now 15-year male patient presenting with dyspnea having the presence of dominant R wave in V1. What is that you need to suspect? You need to suspect some congenital abnormality. So what is that congenital abnormality where you can have the presence of a dominant R wave in V1 is in patients with the Duchenne's muscular dystrophy. So Duchenne's muscular dystrophy, it is a form of congenital muscular dystrophy where you will have the presence of a dominant R wave in V1. And these patients with Duchenne's muscular dystrophy, they develop the abnormal cardiomyopathy, that is dilated cardiomyopathy. So once there is development of dilated cardiomyopathy, these patients, they develop the important symptomatology, that is dyspnea. So dyspnea is a very, very important symptomatology of the Duchenne's. Why there is development of dyspnea? One is because of the development of dilated cardiomyopathy, and another mechanism why there is development of dyspnea in patients with Duchenne's muscular dystrophy is that is because of the respiratory muscle paralysis. Because of respiratory muscle paralysis, the patient will land up in respiratory failure causing dyspnea. So what I want to tell you in this particular ECG is, in this patient with Duchenne's muscular dystrophy, you have dominant R wave in V1. Now, in patients with the Duchenne's muscular dystrophy, what is the sign that you will come across? You will come across this Gower sign. So what is this Gower sign and why do you get this Gower sign? These patients with Duchenne's muscular dystrophy, they develop proximal muscle weakness. That is, there will be weakness of the quadriceps muscle, right? There will be weakness of the quadriceps muscle. And once there is weakness of the quadriceps muscle, remember, they cannot get up from the squatting position. So whenever they want to get up from squatting position, they need to climb on themselves in order to get up and stand straight. And this climbing up, right? So you see, from the sleeping posture, if the individual has to get up, you see how he is climbing on himself. And this climbing on himself to stand up, that is what is called as Gower sign. So Gower sign is present in patients with the Duchenne's muscular dystrophy. Babinski sign, you will have that in patients with upper motor neuron lesion. Kussmaul sign, you have that in patients with restrictive cardiomyopathy, constrictive pericarditis and right heart failure. Square root sign, you have that in patients with the constrictive pericarditis. Okay, so this is another condition where you will have a presence of dominant R wave in V1. So this completes the discussion of dominant R wave in V1. So what are all the conditions? Let me revise. Right ventricular hypertrophy, pulmonary embolism, right bundle branch block, Duchenne's muscular dystrophy, hypertrophic cardiomyopathy. It can be normal variant in children, and in cases of so these are the conditions, and even dextrocardia. So these are the conditions where you will have the presence of a dominant R wave in V1. Now let me take up the conditions where you will have a dominant R wave in AVR. The conditions are the patients with tricyclic antidepressant toxicity, right? That is amitriptyline, imipramine toxicity. There can be dominant R wave in AVR. Then dextrocardia, you will have dominant R wave in AVR. Then incorrect lead placement, that is right arm leads placing on left arm and left arm leads placing on right arm. And the other conditions is they are commonly elevated in case of the ventricular tachycardia. So these are the four conditions where you will have the presence of dominant R wave in the AVR. Now let me show you all these clinical scenarios and the respective ECGs as well. So you see this question first. 56-year female patient presented with history of dry mouth and giddiness on standing. ECG is as follows. The options are neostigmine toxicity, amitriptyline toxicity, opioid poisoning, nitric oxide toxicity. So if you observe the ECG here, what all abnormalities you are having? So first and foremost, you are having the presence of the wide QRS complexes, right? That is one important abnormality. And another important abnormality, if you observe very closely, you can see that you have the presence of the dominant R wave in the AVR, and you are also observing the, so these are the abnormalities, and that particular drug toxicity is associated with dry mouth and as well as giddiness. So which drug toxicity will cause dry mouth and giddiness with dominant R wave in AVR with wide QRS complex? That is nothing but tricyclic antidepressant toxicity, and one of the tricyclic antidepressant here is the amitriptyline. So in patients with tricyclic antidepressant toxicity, what all you will have? Wide QRS, the QRS prolongation will be there, and tall R wave. And next thing is, if you closely observe the QT interval, right? If you closely observe the QT interval, the QT interval is also prolonged. So you need to calculate the QTC. The QTC is definitely prolonged. If you observe the QTC here, it is more than 460 milliseconds in this particular ECG. So these are the three changes that you will observe in amitriptyline toxicity. Number one, wide QRS complex. Number two, dominant R wave in AVR. Number three, presence of the wide QT interval. QTC is prolonged. So that is what you will observe in patients with amitriptyline toxicity, right? Now, moving on to the next question. So if you see the next important ECG with dominant R wave in AVR. So the question is, drug of choice for the following patient is, the options are amiodarone, lignocaine, flecainide and phenytoin. See, this is the ECG. If you take still little background history, this patient is on the digoxin. Okay, this patient is on digoxin and he presented with nausea, vomiting, and there is also the yellow vision in this patient. And this patient presented with palpitations and giddiness. This is what is the presentation of the patient. And when ECG was taken, this is the ECG in the individual. So if you can make out the diagnosis here, the patient has developed digoxin toxicity, right? What are the points suggestive of digoxin toxicity? Nausea, vomiting, yellow vision. And if you see this particular ECG, this ECG, the diagnosis is, it is suggestive of monomorphic ventricular tachycardia. Okay, and in monomorphic ventricular tachycardia, you have dominant R wave in the AVR. And what are the other points in favor of monomorphic ventricular tachycardia? You are having wide QRS complexes. And if you take the heart rate of the individual is increased. So the heart rate, if you observe here very closely, it is something around 200 beats per minute. It is around 200 beats per minute. And if you take the axis also, this is the extreme axis deviation. So there is extreme axis deviation, dominant R wave in AVR, wide QRS complexes and tachycardia. So it's a wide complex tachycardia you come across, and all the QRS complexes, they are of same morphology. So this is suggestive of wide complex tachycardia, right? And this wide complex tachycardia is nothing but monomorphic VT, and the patient is taking digoxin. So secondary to digoxin toxicity, the patient has developed this VT, and secondary to digoxin toxicity, if the individual develops VT, the drug of choice will be the lignocaine. Okay, and you have to remember that you should understand the patient should be hemodynamically stable. In hemodynamically stable VTs, we give medical management. In hemodynamically unstable VT, DC cardioversion will be the treatment of choice. Okay, now when will you give amiodarone as a drug of choice? If amiodarone is the drug of choice, if the VT is secondary to some other pathologies apart from the digoxin induced VT. Like if, for example, you take myocardial infarction induced VT, a stable, hemodynamically stable VT, there amiodarone is the drug of choice. But here the patient is having a background history of digoxin intake. Okay, so that is the reason why the answer is lignocaine in this question. Now you take the next question. So this is the ECG of the individual and tell me what is the diagnosis. The options are dextrocardia, right arm, left arm lead reversal, digoxin toxicity, lateral wall MI. Now if you closely observe the ECG changes here, right, if you closely observe the ECG changes here, number one, you can make out that there is global negativity in lead 1, which is not seen in a normal individual. And the next important abnormality you can see that is, you have a dominant R wave in AVR. Just now we have seen one condition where you have global negativity in lead 1 and dominant R wave in AVR, that is in dextrocardia. But in dextrocardia, what is that we have discussed? We also have discussed that there will be poor R wave progression. Now you should understand the concept of, okay, you see this, right? You should understand why there is poor R wave progression in dextrocardia. What is the reason? The reason is that in patients with dextrocardia, the heart, instead of being on the left side, the heart will be present on the right side. And where are your leads placed? Your leads are placed V1, V2, V3, V4, V5, V6 towards left side. And your heart is present on the right side in dextrocardia. So the electrical activity is moving away from V1 to V6. So when the electrical activity is moving from away from V1 to V6, you will have poor R wave progression in dextrocardia. But you take in the following ECG what we are discussing now. So in the following ECG what we are discussing now, if you take the R wave progression, you have the normal R wave progression. So the presence of the normal R wave progression with global negativity in lead 1, dominant R wave in AVR, all these are suggestive of right arm, left arm lead reversal. Okay, so in RA and LA lead reversal also you will have dominant R wave in AVR, global negativity in lead 1, but poor R wave progression will not be there. Okay, so this is about the right arm, left arm lead reversal, right? Next, now the last important abnormality what we will be discussing regarding the R wave is poor R wave progression. What is the criteria for poor R wave progression and what are the conditions where you will have poor R wave progression? We will discuss that now. So if you take this ECG and when you closely observe this here, you can see that in lead V3 the R wave is small, right? In lead V3 the R wave it is small. And what is the criteria for poor R wave progression is when the amplitude of the R wave, if it is less than 3 mm in lead V3, that is considered as the poor R wave progression. Okay, so the amplitude of the R wave in V3, it should be less than or equal to 3 mm in V3, that is called as the poor R wave progression. Now, what are the conditions you will have the poor R wave progression and what will be the clinical scenarios? Let me discuss. The question is, 52-year male patient came for a routine checkup to a camp conducted in his workplace. He gives a past history of a cardiac disorder. We don't know what exactly is that. He says that there is some cardiac disorder in the past. His ECG is as follows. What is the diagnosis? The options are: the patient underwent AS3 device closure, patient had old anterior wall MI, hypertrophic obstructive cardiomyopathy, then the rheumatic fever. Okay. So now what is the abnormality you are having here? The abnormality that you are having, if you closely observe, so first and foremost, there is poor R wave progression. Okay, because in V3 if you observe, the amplitude of R wave in V3 it is less than 3 mm. So this is a criteria for poor R wave progression. And along with that, what are the other abnormalities you are having here? You are having the presence of the QS complexes. Presence of QS complexes in the anterior leads. So you have QS complexes, poor R wave progression, and T wave is also inverted where in the anterior leads. So this is suggestive of the old anterior wall MI. In old anterior wall MI, there is poor R wave progression. I'll tell you the reason also, because in anterior wall MI, the anterior wall is dead. So when anterior wall is dead, it will not produce any electrical activity. So that is the reason why V1 to V4 will not be able to pick up any of the electrical activity. So that is the reason why you have poor R wave progression in V1 to V4. Okay. So one condition where you will have poor R wave progression is old anterior wall MI, right? Next. So the other condition where you will have the poor R wave progression is the left ventricular hypertrophy. So what is the criteria for left ventricular hypertrophy? That is the Sokolov-Lyon criteria. So Sokolov-Lyon criteria is the SV1 plus RV6 that should be more than or equal to 35 mm. There is a criteria for LVH, left ventricular hypertrophy. And you can see here that the R wave is very small in V3. And what is the amplitude? It is less than 3 mm. So that is also the criteria for the poor R wave progression. So the conditions where you have poor R wave progression is old anterior wall MI. Next, in patients with the left ventricular hypertrophy, right? Then the other conditions where you can have the poor R wave progression is the evolved anterior wall MI, because even in case of evolved anterior wall MI also, it is complete transmural infarction of the anterior wall. So electrical activity generation is not there, and thereby there is poor R wave progression. So this is about the abnormalities of the R wave. So number one, where you have the R wave in lead V1, where you have a dominant R wave in AVR, and where you have poor R wave progression. So this completes the discussion of abnormalities of the Q wave and abnormalities of the R wave. Thank you very much.